I'm Laura Bonnell, and this is the Living with Cystic Fibrosis podcast coming to you from Detroit. Please subscribe and even rate and comment on our podcasts when it moves you. I learn something new with every podcast, and I'm always inspired by the people that are showcased here. We don't give medical advice. You need to connect with your doctor for that. I hope that this Living with Cystic Fibrosis podcast educates you and sparks some volunteering or advocacy. The CF community needs people like you. Thanks to our sponsors, Viatris and Vertex, for their support. Dr. Ames and Dr. Bupp are deeply committed to their patients, but like so many clinicians today, they're spending an extraordinary amount of time battling insurance companies, and between prior authorizations, step therapy, and coverage denials, physicians and their teams are buried in paperwork, often at the expense of patient care. And this was recently highlighted by Boston Globe reporter Jonathan Saltzman, who reported on a new program that was rolled out by Blue Cross Blue Shield of Massachusetts. And the insurer says that the plan is meant to control rising healthcare costs for its 3 million members, noting that costs have increased by 30% since 2021. And the program targets physicians who bill for the most expensive visits. And we will explain that more as we get going on this interview and what it really means. Doctors argue that patients with complex and rare conditions require more time, not less, and that is so true, and warn that this approach could lead to rushed appointments and strained doctor-patient relationships. And this is especially true in the rare disease community that we are in. So today we're joined by Dr. Elizabeth Ames and Dr. Caleb Bupp, and we're talking about what this looks like in real life for them, for us, especially in the rare disease community, where delays and denials can be devastating. We should also mention that we are all on the Rare Disease Advisory Council in Michigan, which is often referred to as the RDAC. That's the acronym. And although we are not speaking on behalf of the council, we just wanted to make sure you know we're not speaking on the council's behalf. The purpose is for the issues like this that will help the entire Michigan rare population, because it does give the rare disease community and their spouses and caregivers a voice. And everyone in Michigan can participate and speak during public comment in the RDAC. So we're going to get rolling with these two wonderful doctors. I'm excited for you to get to know them. Thank you both so much for joining on this podcast. I'm excited to have the two of you. And like I've told you and emailed you and talked about it, you're two of the smartest people I know. And I'm very excited to have you both. You know so much and have such a great perspective. I think everyone's really going to love all the information and everything that you talk about. And we're always going to start with Dr. Ames answering first, just so we don't get confused, so everybody knows. And I guess I first wanted to ask you why you became doctors. What inspired you and sent you in this direction?
Oh gosh, going first is hard. I mean, it's kind of come full circle, right? Like when I was young-ish, like ER was like in its heyday, right? Now that the pit has like resurfaced as sort of this like medical drama, it's funny because like I think ER was one of the first times where I remember being like, oh my gosh, I have to do that. Like just like helping people and like, anyway, so I think that was sort of this romanticized version. And then as I went through college, I was doing work like in a genetics lab. And I loved it. I fell in love with it. And that really stuck with me. That like, you know, seeing kids in clinic, that it was a lab thinking about like myotonic dystrophy and muscular dystrophies and just how impactful that was for a child and for a family's life. And so that really stuck with me and made me want to do an MD PhD. And then when I was doing my PhD, it was thinking about like genetics in heart development. And I thought, oh, maybe I'll be a cardiologist. And then I realized like physics was a lot of cardiology, and I was like, hard pass, hard pass. But the pediatrics is just so, you have such an ability to change the trajectory of a patient's life. Like adults make their own decisions and are set in their ways, but a child, like there's so much you can change over their lifetime. And so I just really fell in love with it. So I'd say that's sort of how I came to be a pediatric geneticist.
Thank you so much. And Dr. Bupp.
Yeah, my journey has been one of not knowing what I wanted to be when I grew up, and sort of stumbling my way forward at times. So I was in college as a biology major and didn't really have a sense of where life was headed. And my college offered a medical missions opportunity. So for 2 weeks in between my sophomore and junior year, I went to Kenya with a small group of college students and a couple of medical professionals. And we worked out of a dirt floor metal building. And we would, drive about 45 minutes to get there from where we were staying. And as you were driving there, you were seeing people walking that were headed there to get care. And, experiences like that are very transformative. But one particular a patient that we saw had been thought to be deaf. And when we saw them, it was just because they had so much earwax impacted in their ear that it literally was hydrogen peroxide and digging it out. And we took someone who was thought to not be able to hear and gave them hearing. And that's pretty wild. And so that's kind of what crystallized the idea of heading to medical school. And then, found my way to pediatrics. And when I was doing my peds residency in the middle of the winter, admitted a little one with RSV, a really bad respiratory virus, and that kiddo had Pompe disease. And it was right as the enzyme infusion treatment was coming out for that. And they were on that treatment. And that was a condition that I had read about in a book because it's like a standard teaching condition. And then the geneticists started showing up and I was like, who are these people? And why did they know about this condition that's only in the book? And again, that sort of just sparked my interest. And then I think knowing Beth, when you love what you do, it's infectious. And the geneticists and the people that you work with, when you're like, wow, they really like what they're doing, that can really light a fire. And I feel like that's kind of what got me to this place. And it's really fun now to be on the other side of things and to try to light some fires for other folks when they have any interest in genetics and medical genetics.
Beth, I'm going to give you a second to think about this while I mention something else, because I was going to ask you both this next, but Caleb, you already said it. What sticks out to you in your practice, Dr. Ames, about something that was like, wow, it was so cool that you were able to help or give a parent of a patient some information? I'll let you think about that for 1 second. But I wanted to say that one thing I just did a video about was after Tatiana Schlossberger Kennedy died, it just reminded me that it doesn't matter how much money you have. Linda Eastman, Paul McCartney's first wife, she died. They have millions. Everybody has tons of money, and it isn't about the money. It isn't about the privilege. It isn't about all of that. It's about you two. It's about the scientists who have the answers. And I just want to remind people, this is where we need to put our focus. The answers are with the scientists and the physicians. You all have the answers, and it's with your community when you're like, hey, which is exactly what I want to ask you in a couple of minutes, Dr. Bupp, about what you did in this very situation. It's about the scientific community, like bouncing things off of each other. So it's so important we got to raise science back up where it was at its height when we respected it completely and loved it and embraced the science community. So that's my dream for 2026. But Dr. Ames, is there something that stands out to you when you thought, this is why I got into it? I was able to do this for so-and-so.
I guess I've been so lucky to take care of like so many kids that have like changed how I think about medicine. There's one patient that I took care of as a resident. I was just a resident in the PICU, just doing my life. And she had regression, and she'd had this long admission to try and figure out why, like, as a 3-year-old, she stopped being able to walk, and no one had figured it out. And they'd gotten some labs and nothing was really clear. And then she came in and she was really sick. She had pneumonia and she was really sick. This was, back when this condition, Tango 2, had literally first been described. And I was like, man, I think this could be Tango 2. And I remember my attending like kind of making fun of me and was like, well, are you sure it's not like Tango 1? Like, what? It's just this gene name. It's so random. But sure enough, she had it. And the family had had a baby who died of SIDS at 10 months of age. And the baby also, like, after the fact, we figured out also had it. And getting back, Laura, to exactly what you're talking about, when we first diagnosed this little girl, like, it was great because like I was in the PICU and then I switched to my genetics rotation and I got to do her genetics consult and got to order her testing. And anyway, it really came full circle. But at that time, we didn't know a lot about Tango 2, right? Like it was this brand new condition. It was real serious. But over the last few years, we now know that B vitamins, something as simple as a B vitamin, makes a huge difference. And so now she's on vitamin supplements and doing so much better. And so, again, science, advances in these spurts. And so that's something that, I've gotten to continue taking care of her even as an attending and to sort of see us understand the disease as science advances has been really, really cool.
That is wonderful. Wow. I mean, that's such a success is an understatement, but I mean, for those parents, it's everything. So that's incredible. Thanks for sharing that. And one of the things that we have talked about, the three of us, is insurance and the challenges. And how do those insurance barriers change what you're able to offer your patients? And we'll start with you, Dr. Ames.
Yeah, we've talked about this. Here's an incredibly timely example. I have a patient who has MPS IV, so it's a lysosomal storage disease. There's miraculously an enzyme replacement therapy. And her insurance policy as of January 1st changed, and that they only cover medicines that are able to be self-administered. She is a 15-year-old girl who needs an IV infusion of a medicine every week. Like, there's no way you can ask a child to self-administer their own infusions, and it's just some rule that an insurance company dreamed up as a way of not having to be able to pay. And so, like, that's an example of just like, what am I going to do? Like, I'm going to fight it, but it's, there's always going to be a new rule that, someone dreams up.
And before I hear yours, Dr. Bupp, I have to say, I was on an insurance call yesterday just for myself. And I know that the initial people we're talking to are just reading things, which is also scary because he asked me if my husband had the hysterectomy, when of course it was me. So it's just like, I don't know, it's brutal. It's brutal out there for insurance. But Caleb, what are your thoughts on that same question?
I think an example of the chaos of this is when a patient comes, when we get information. Honestly, our first question, probably even before like, why are they coming, is what insurance do they have? Because it is an immediate fork in the road, depending on what you got, for what care we're going to be able to deliver, whether it be diagnostic testing or treatments. And then even though we know there's that fork in the road immediately, there are so many forks because of different policies. And like Beth said, are constantly changing. It is impossible for any healthcare provider, I think, to know in that moment exactly what the options are going to be. So up front, the care that you're delivering is almost uncertain because I'm not really sure if the testing that we'd like to do is actually going to be possible, because we're going to have to figure it out and prior auth and those sorts of things, or the treatments. So it's like this weird start-stop approach to medical care, because you have to it's like playing a video game. You have to pass the next level before you can figure out what the next steps are. And that is challenging at baseline. And honestly, I think it's what a lot of us experience with any healthcare that we get. It is exponentially more challenging when you're dealing with rare disease, genetic conditions, things that aren't quote unquote common.
What do either of you think about how this insurance situation has evolved and gotten so challenging for everyone, and how much time are you spending time every single day on insurance stuff and your staff? I mean, it's got to consume a lot of time.
I would say I'm really lucky to have some really great support staff, but there's a person whose entire job is insurance authorizations. There's a person who does exactly like Dr. Bupp was saying, genetic testing authorizations. And then there's another person who does medication authorizations. It's mind-boggling how, it's sort of like that arms race. People the insurance company puts all these rules up. And so then the healthcare system, builds up all of these people whose job it is to jump through the hoops of insurance. It really is mind-blowing.
And Dr. Bupp, your description was people can visualize what a challenge it is just to get help.
I mean, in the genetics world, there's a role called a genetic counselor assistant, which I think is what you were referencing. That job didn't exist 5 years ago. It literally had to be created as a new profession. We have a job description in our organization for it now, because of the complexities that with trying to unravel these insurance situations.
And as we talk about this, Dr. Bupp, I also want you to talk about the story of the 12 people, the disease that you were able to diagnose and get medications for. And we're talking about your co-discovery of treatable genetic syndrome caused by ODC1 mutations. And I'm reading that because you're going to have to explain it, but it's a syndrome that is now termed Bachman-Bupp syndrome. And it's an incredible story if you can share that with us.
Yeah, we had a patient come to see us who had developmental delay, a low muscle tone, which is a pretty standard thing to come to a genetics clinic for. And we were able to get genetic testing, not always an easy thing to do. And those results came back as sort of uncertain because we didn't really have any disease that went with them. And through a series of very fortunate events, I connected with an MSU researcher, Andre Bachman, who had worked on this particular gene, but just not in human disease. Putting some pieces together, we were able to describe it as a new disorder, which was super exciting to have our patient be really the only one that had it. And then there was the question of treatment being a potential. And rare disease treatment is really tough to develop because there aren't a lot of people who need a treatment. So there's not a lot of incentive financially for pharma companies to develop this. It's, part of the reason why things like gene therapy are so expensive, because there's not a lot of people who are going to get it. So you kind of need to have that price tag be high enough to justify the research and development. But in our particular situation, we had the possibility of repurposing a drug, which really balances the books quite a bit from a R&D perspective, because you essentially already have the drug and it's been tested and validated. So working with the FDA to get approval to sort of give that a try. And then we're able to give it to our first patient and saw some really incredible results as far as improvement in muscle tone. These kiddos don't have hair, so she regrew all her hair, which was very easy to see externally. But yeah, we're up to, I would count it at 21 right now. We just heard from another patient in France a couple weeks ago. So there are not a lot of people that have this. The drug is, again, being repurposed, but it's not FDA approved for our indication. Not all the patients are in the US. So the idea of doing like clinical trial is incredibly daunting for something like that, let alone just having people even be aware that this condition exists if a provider sees a patient and not knowing what's going on.
Thanks for explaining that. And one of the things that got us talking about this podcast and the challenges facing insurance was this article, Dr. Ames, that you shared, the Boston Globe reporter that did an article about Blue Cross Blue Shield of Massachusetts and flagging doctors who bill for the most expensive visits. Can you explain that a little bit and talk about your concerns about that?
Yeah. So when you think about all the different types of doctors, there are, there's primary care doctors. Everyone, when they go to a doctor's appointment, sort of has different expectations, right? If you're going to go to your primary care doctor for a checkup, you sort of have an idea, okay, well, we're going to talk a lot about my health and sort of do a really comprehensive review. But if you're taking your kid in because they have a sore ear, and you're worried about an ear infection, that's an appointment that's going to be shorter, right? And so one of these things that, rules that insurance companies have built up is sort of, paying doctors by how much time they spend on a patient. And so when, you're just looking in a kid's ear and you see an ear infection and then you maybe do a prescription for antibiotics, that's pretty straightforward. But when you think about seeing a patient in clinic for a genetics visit, I mean, think about so Caleb had that child who had that genetic test result, right? And it was an uncertain result. It wasn't really clear. That takes a lot of time, right? I can't imagine how much Caleb probably thought about it before, talking to the family, right? And that's really helpful time, right? It saved that child's life, certainly their development. And geneticists tend to bill for a lot of time. We tend to spend a lot of time with our patients, right? We go through, we draw out a family tree, a pedigree. We spend a lot of time talking. And so geneticists bill for that time. We have longer appointments. And so the concern is, well, we as a specialty are going to be targeted by these insurance rules because we have these complicated visits, because we take that time with our patients. So it'll be interesting to see how much that sort of ripples out to other states and other insurance companies.
How worried are you about that?
I mean, at the end of the day, I'm still going to see my patients and I'm still going to, I'm not going to spend 15 minutes with them because insurance companies aren't going to pay me more than that, right? I think maybe I was overly optimistic, but, at working in a big healthcare system, you have to believe that there's going to be some higher level advocacy and hopefully that's where a change will be sort of made is on a much higher level. But it sort of feels like completely out of my hands.
And Dr. Bupp, what are your thoughts? I mean, isn't the comparison if you're an hourly worker and you work another hour, you expect to get paid? Is that a fair analogy just to help people understand? And what are your thoughts on what's happening?
Yeah, I think it is impossible with genetic conditions, with rare disease, to walk into the room and say, what brought you in today? To knock things out, to get your documentation and move on to the next patient in 15 minutes. I spent an hour and a half yesterday with a patient because they have something that there are maybe 3 or 4 kids in Michigan who have, and we were trying to look at treatments and other connections. And, that was the right thing to do because that diagnosis was new and fresh for the family. And the other thing is nobody else is going to be able to do that. Like the family even was telling me, like, we can't talk about this with family or with other healthcare providers because they never heard of this. And people are like, well, what is this? So even just to sit with somebody who has heard of your rare disease is huge as far as like a therapeutic benefit there. But yeah, there is. I like your arms race analogy, Beth. With there's always sort of insurance companies are doing their thing, and then healthcare companies, labs, are kind of do their thing, and then it ebbs back and forth.
And is it fair to say it seems short-sighted by the insurance company because in the long run, it will save them money. You get a diagnosis or you hear from the patient and the parent, and you're able to then treat it, get the correct medication. It seems like in the end, it's all going to balance out and work.
Yeah, there's this concept called the diagnostic odyssey, and the Every Life Foundation. We can maybe even share this in the notes or something. They have some excellent information about the diagnostic odyssey patients. The extra healthcare costs are hundreds of thousands of dollars. It is months and years of waiting for a diagnosis, seeing 3-4 times the number of doctors that anybody has. And that has a direct financial cost because it just takes so long to get to the answer. And I think that is tangible. But they also do a really good job of pointing about the indirect costs, right? The time lost at work for parents, going to appointments, the need for accommodations in the home for kids who need extra assistance and stuff like that. So it compounds very quickly to being a real and substantial problem. And that's the challenge with all rare disease, right? Individually, they're rare, but when you put them all together, it is not rare in the least. And so these issues that we're talking about, they don't just affect a couple of kids. They affect a couple of kids who have each disorder, but when you put it all together, it affects a lot of kids, particularly kids that access healthcare. I mean, the percent of kids that are in the hospital that have genetic and rare disease, it's astronomically high because that's who is in the hospital.
And that is great. It's definitely in our show notes now. By the time this airs, we will definitely do that. Every Life is fantastic. And I have to say, just for me, I had to leave a full-time job and do it part-time. And I was fortunate that my husband obviously was working full-time and we could afford to do that. But I now, because I'm older, was thinking, wow, not only did it impact my ability to work full-time because I had to take care of my girls, but it's also going to affect my retirement because I had to go part-time. There's less money for my Social Security. It affects your financial life forever. And I didn't realize that until I got older, and I thought, wow, it would have been so different if that had changed. So if that had, if I was able to work full-time and just the way insurance and everything is laid out and having to care for my kids, it wasn't possible, but that's so very true. And I wanted to ask both of you, do you worry about repercussions even for speaking out about this? And obviously everyone wants to work together and you want to hear feedback from the insurance company. And like any discussion, you want to hear all sides and learn from each other. But I wanted to hear from both of you. Do you worry about that? About getting flack for speaking up?
I guess I think of myself as such a tiny piece of what is just a monstrous healthcare system that I can't imagine an insurance company caring a lot about like my personal thoughts and feelings. It is really tough when you've gone through trying to get a medication covered for a rare disease, and you go through the steps of appeal, and part of it is a peer-to-peer. I've never really had a peer, right? Your peer is assigned. I think the best I've ever gotten was a pediatric endocrinologist, but it's some other physician who doesn't know genetics, doesn't know rare diseases, and yeah, I mean, I think those are the times when I really struggle because it's a one-on-one conversation, and you're just trying to do what's right for the patient, and this physician employed by the insurance company is just trying to deny coverage.
Laura, I had a peer-to-peer for one of our Bupp patients, we discovered the disease and it didn't go through. So when I did the peer-to-peer with another physician from the company, they said, oh, I see you discovered this disease. Oh, and you've published on the treatment. Like, oh, okay. So it was totally fine, but like there was a barrier right there. And again, this is a very, very niche example, but even something that should be a complete no-brainer still got stopped.
And I would think this is stressful, added stress to both of you, added stress to whoever is in charge, of the insurance for the family. It's either an adult patient or the family. Do you see that as well?
Yeah, I mean, it's incredibly stressful. I mean, because, usually we get faxes saying like, oh, this has been denied, and we start working on it. But, the family gets a letter, it's delayed. We try and have good communication and say, hey, we got this denial, we're working on it. But I think it's just I think it's like death by a thousand cuts, right? Like every denial, like all of those letters that come, it's just hard on families. They're saying, oh, my child, I'm not myself, like, I'm not worth covering, like that's really hard.
Yeah, it is. The reality is, I think what you experienced, Laura, that if life takes you in this direction, it is going to become your full-time job to advocate for care, coverage, resources, assistance, therapy. It is impossible to continue the life as you are currently living it and add it on because it is so much extra there. But I would just say from an advocacy standpoint, I think the power of people sharing their stories is incredible. I think the voices of rare disease patients and advocates have made a major impact with a lot of the shifting with research funding that kind of has brought it back in many ways from where things were headed in the last year or so. So I do think it has been a benefit.
And I wanted to ask you two things. One is, how does it impact your staff and everybody that works? Because they're not only doing their job, well, and I guess handling the insurance is also their job now, but it does add a lot of pressure to your whole staff, right?
Yeah, I'm really fortunate to work with people who sort of rise to the challenge. They relish the fight. If insurance is going to deny it, then we're going to fight it. Yeah, and I think that we try and have that be a party line. Like there are very few times where if something's denied that I just give up. And I think that when you have a team where everyone feels that way, like this is a fight worth fighting. On the days when you feel like you can't fight, it's helpful to have others that are there being like, no, we got to do this. We got to do this.
I'm going back to where we started in the beginning. How did you end up doing what you were doing? Neither of our stories involved, I just really loved insurance appeals and reading policies. So and I think that's why anybody went into this. And there's also not really training for this. You just learn it by real world experience. And it is, I call it the dirty underbelly of genetics. This isn't why anybody went into doing this, but it is a practical reality of it. So sometimes, maybe not sometimes, a lot of times it is, yeah. And you have people's lives in your hands proverbially, and you're advocating for what you believe is right and true. And it is really frustrating when somebody who typically doesn't really have the full perspective says no.
So frustrating. And also, unless you're a person who has a flexible job, when does someone have time, a parent or a patient, to sit on the phone for 2 hours with an insurance company, let alone somebody working in a doctor's office? But there's that huge time commitment and note taking. And who did I talk to? What did they say? I got to follow up with this. They don't understand that. There's a whole education process and so much going back and forth. And that brings me to You two and so many physicians and scientists are so involved. As I mentioned in the introduction, you're on, and we're speaking as doctors and a foundation, not as the RDAC, the Rare Disease Advisory Council, but you are involved and on that council so that you can hear from the 1 million people in the rare community and to help. And that's something I do talk about with doctors all the time. You need to be involved. You need to understand legislation because you and your patients are affected by this. So for you both, why is it so important to be involved?
I mean, I love seeing patients, right? And I love that I have families that I've gotten to know and see their kids grow up. But I think that that's sort of, on a day-to-day basis, those are like the tasks that you do. And I think that when you think about advocacy or sharing more broadly how important it is to recognize rare diseases, it's sort of like adding the technicolor to my job, right? Like, things are kind of black and white, but then when you zoom out and you think about rare diseases and how important it is for a person to be able to have that diagnosis, to end the diagnostic odyssey. And then, the holy grail is like, maybe there's a treatment available, like being able to share those stories more broadly is so important because some people just don't. They've had such, they've had lives where they've never encountered someone with a rare disease. And you can't really explain it to a person unless you've had some personal experience with it. I think it's just really important if there are people, making decisions in the government or insurance companies, like they have to know that human side of what it's like to have a rare disease.
I think rare disease advocacy, there is power in numbers. One person can be a huge difference maker, but it's not 1 + 1 = 2. It really exponentially grows. And I think with things like rare disease advisory councils, that gives you a better connection within your state for state government and for advocacy. And I also think, or I hope, that it gives a place for an individual to plug in that can then magnify and amplify their voice so that they don't have to be by themselves.
Thank you both. And as we wrap up, we just touched the surface of what could be happening to physicians as far as trying to take more time with patients and making sure that gets covered for you on your end. But I wanted to ask you about step therapy. We would hope that when doctors say you need, I don't know, Levaquin, whatever, that just popped into my head, but whatever it is, that the patient gets to take that drug. But so often the insurance company dictates and says, well, first we want you to try and fail, try. And then if you fail, then we'll do what your doctor says. We're working on this legislation, but how frustrating is that for both of you?
I mean, it's really frustrating. I will say, in my experience, I haven't even, I think that there are places where the insurance companies dictate treatment, but for me, it's been mostly like examples of like, it's just not covered. It's not a covered benefit. There's a new medication for Barth syndrome. So I have a patient with Barth syndrome and we tried to get it covered and his insurance was like, yeah. And you have to fill out that form and it says, what other therapies have you tried? There's literally nothing, So, this is the first medication that's ever been available for this condition. Well, it's just not covered, So I haven't had insurance companies tell me what medications to use. And I bet, Caleb, you've probably had this experience that they sometimes tell you what genetic tests to order. And oftentimes it's the wrong one.
So what do you do in that case? Just override it or?
Yeah, I try and appeal it.
Insurance companies have to operate off of policies. That makes sense. And it's hard to keep those policies completely up to date. But there probably is a world where those policies shouldn't be ridiculously out of date. There's still language out there about genetic testing being experimental. And it hasn't been experimental for 20 years. So I think, again, there are some of these labels that can get put on diagnostics or treatments that, okay, maybe there's a version where it's experimental, but how is something experimental if there are only 100 patients in the world that have it? This is rare disease and this is science, where we are always sort of, on the edge of clinical care and research. And I think most rare disease patients, families are totally fine with that. They don't have any illusions that this is a broad thing that everybody experiences. And I think that's where I've been very thankful for the partnership that you get from patients and families that are really the ones that make a huge difference, right? Laura, you're a great example of that, right? It takes somebody getting a bee in their bonnet and saying, enough's enough, and being willing to make enough of a stink to get something done, because it truly is the squeaky wheel that gets the grease with a lot of this stuff.
Yeah, that's so true. And even unless something has changed in the last month or two, lung transplants for cystic fibrosis are still considered experimental. And I mean, they're not, but that leaves the insurance company to say, we're only going to pay this much. And that's one of the things we help cover, but it is so challenging because you do just want to have a meeting and say, come on, can we all just agree on this or that and get it done? Do either of you want to say anything maybe that we didn't discuss before we wrap up here, or anything that comes to mind that you think is important to end with?
Things are rough, yes, but they are better than they used to be. And that's not a justification, but just trying to think somewhat more hopefully. The number of gene therapies that exists, it's not single digits anymore, and that's tremendous. The access to diagnostics is vastly improved from where it was 5 or 10 years ago. There are still opportunities all over the place, because the more we know now, the more we have to work with, and the more battles to fight and things like that. But just trying to fill that glass a little bit towards half full with considering all of this.
Yeah. And I also think that if it wasn't for compassionate doctors like the two of you and others, it would be so much harder for patients and parents. If nobody was being sympathetic and saying, I get it, I understand, we're going to help you, oh my gosh, we would be bashing our heads against the wall every day. It would be horrible. So I'm so glad you and others are involved. And Dr. Ames, you kind of get the last word here if there's anything you think of. And if not, that's fine too.
I mean, I totally agree with Caleb that, again, I still think that the arc is towards progress. And when I think about even in the last year, different gene therapies that have become available or have proven to work more, I mean, again, that is an arc towards progress. But I think the other piece of this is something that we've already touched on already, is that sharing stories and using a collective voice to speak louder is so important, right? Like, even in the last year, some of those FDA approvals for rare diseases have come because of patient advocacy. And that's been true in the past as well, but there's always a role for families and patients to share their stories, because I think we're all human and stories stick with us better than a chart or facts. And so I think that's just really important, is to continue sharing stories.
Well, thank you both for doing this podcast. I'm glad that people get to know you a little bit and hear all that you're doing and your thoughts on so many things that impact us all. So thank you both.
The original music in this podcast is performed by Kevin Allen.
It's not complicated.
Who happens to have cystic fibrosis.
We all got our worries and fears. I know it's got you frustrated, but loving you is so alright.
This has been the Living with Cystic Fibrosis podcast. For more information and to learn more about the Bonnell Foundation, visit our website at thebonnellfoundation.org. That's the BONNELL Foundation.org. This podcast was sponsored by Vertex Pharmaceutical, The Science of Possibility, and Viatris. It was produced by Jag and Detroit Podcasts. Follow our show in Apple Podcasts, Spotify, or wherever you're listening right now.